Hi everyone. In this video I'm going to be going through a series of various gait abnormalities which are commonly seen in clinical practice. And fingers crossed the GIFs that I have in this video do work, but let's see how this goes. Anyway, before we get started with exploring what the various gait abnormalities actually are, we first have to define what gait is. And if you've already seen my other video when I looked at a detailed look at the gait cycle, then you're already covered. But for those who haven't, basically the gait cycle is the way in which a person walks. It contains 7 stages, and these 7 stages must occur in succession with each other essentially to allow for an efficient manner of walking. So examples of stages include what we call the loading response, when we first put weight on a particular foot, mid stance, which is essentially the middle of the gait cycle, toe off, which is when we lift our toe off the ground, as the name suggests, during the gait cycle, and heel strike, which is when we hit our heel on the ground when we first are attempting to shift weight onto a particular leg. So those are just some examples, but the gait cycle contains all of those 7 stages in a particular order to allow us to essentially walk in the most efficient and least damaging manner possible. Now, gait abnormalities can occur, and essentially, if you think about gait, the main organs that are associated with the gait cycle are obviously the muscles of the leg and some muscles of the back. So gait abnormalities have to be associated with all of these muscles and essentially things that go wrong with these muscles. One of the gait abnormalities that I'll show you today is not actually related to any of those organs directly, but in fact is related to brain lesions that can cause for gait abnormalities, because as you know, with any organ or any thing within the body, the brain controls it. So if there's something wrong with the brain, then there's going to be something wrong with that organ, and the same principle lies here with the gait cycle. So the first gait abnormality that we're going to be looking at is called an antalgic gait. Now, an antalgic gait is when essentially, if we break up the word antalgic, algia refers to pain. So the person who is experiencing this type of gait is going to be experiencing pain when they walk. So as you can see in the GIF in the center of the slide here, the man is walking away from the camera, and if you can notice something about the way that he's walking, you can see that he spends a lot less time on his left leg than he does on his right leg. So have a look at his leg as he walks here. You can see that he's spending a lot more time on his right leg than his left leg, which essentially means that he is likely experiencing pain in his left leg. So firstly, let's just label what this gait is. So this is an antalgic gait, and specifically looking at which leg is affected here. Since the left leg is affected, we would call this a left-sided antalgic gait. And just thinking about the various muscles that are associated with the legs, obviously looking at this GIF here, it's not very clear which specific muscle is affected, and the way in which we're able to tell which muscle is affected is based on which part of the gait cycle has been affected. So for example, if let's say the heel strike phase has been affected such that the person does not have a heel strike, so when they place their foot on the ground they don't go heel first, then it's likely that there is an issue with one of the dorsiflexors of the foot, since the dorsiflexors are responsible for pronation of the foot. I should say dorsiflexion of the foot. So if one of those muscles have been affected, then we can narrow down that particular injury to that muscle. But in terms of an antalgic gait, sometimes it can be quite difficult to tell. In this case, since it is something that is weight bearing, so an antalgic gait means that a person is unable to put weight on their foot or on their leg, it's likely that the pain that this person is experiencing may be related to the knee joint itself. So there may be some sort of pathology with the knee joint. There may be something wrong with the ankle joint as well. And in addition to all of these things, there are many muscles associated with the leg, as you know. So there may be something wrong with those muscles in the first place. So for example, if there is weakness, let's say if we think about the stance phase, which is a part of the gait cycle where we put weight on the reference leg, and say if we take the left leg, which is the injured leg, as the reference leg, the key muscles that are associated with the stance phase, if we think about the movement of the leg within the stance phase, we are allowing for extension of the hip joint. So the hip extensors, which include the semitendinosus, semimembranosus, and biceps femoris. So there may be something wrong with the hip extensors. So some sort of hip extensor injury. Another part of the stance phase is knee flexion. So some of the knee flexors may be associated with this particular condition. So these may include, say for example, the muscles that we talked about before, so the biceps femoris and semitendinosus, but other muscles that are associated with that small knee joint as well. Now this is a weak muscle, but the popliteus may be associated as well. So hip extensors and knee flexors. So as you can see, there can be many different causes of an antalgic gait, and therefore we can get many scenarios or many situations when we're actually having this presentation. And this is where the asking for the patient to perform the gait cycle is very important, because the gait cycle is a very easy thing to assess. You are assessing it when the patient is walking towards you from the waiting room to your consultation room. You can even ask the patient to perform their walk when they're in your consultation room. So performing the gait cycle is very easy, and therefore assessing for an antalgic gait and asking after that for the patient to perform specific maneuvers is very important as well. Alright, so the next gait type that we're going to see, or gait abnormality, is what we call the Trendelenburg Gate. So Trendelenburg Gate. Now the Trendelenburg Gate, as its name suggests, is a bit confusing to know based on just its name, and that's why antalgic gait was probably more helpful. But with the Trendelenburg Gate here, if you know anything about hip anatomy, you'll remember that the muscles that are associated with stabilization of the hip essentially include the gluteus muscles. So the gluteus, sorry, let me just rewrite that. So gluteus maximus, medius, and minimus. Now, in reference to a Trendelenburg Gate, essentially what allows for the prevention of the pelvis. So when you're walking, your pelvis obviously moves, right? But when you lift your legs, so say for example, this, we're looking at the back of a person, and this is a very rough diagram. So this is the left leg, right leg, and this is a very rough diagram, but this is the pelvis. When you lift, say, your right leg, such that the leg is lifted up like that, you would expect your pelvis to move upwards as well, because it's pulling that leg up. And the muscles that allow for this action to occur are the gluteus muscles, and specifically they are the gluteus medius and gluteus minimus. Now, what happens in a Trendelenburg gait is that we actually have weakness of the gluteus medius and minimus muscles, which means that when a person lifts their leg, instead of the pelvis rising, we get a pelvis droop. So if you can see this elderly woman here, have a look at her right leg, and you'll see at the same time, by having a look at her right waist, whenever she lifts her right leg, her right waist always droops. I'll give you some time to look at this because it's a little bit difficult on this particular GIF, and that's why I've chosen this GIF, because these gates are not going to be obvious to you all the time. So having a look, I'll explain it one more time. Whenever this person lifts their right leg, you'll see that their right hip droops. Can you see that? Alright, so this diagram can be a little bit confusing, but essentially the principle is that, say if we lift the right leg and the right side of the pelvis droops, right? If that occurs, there's not actually weakness occurring on the gluteus medius and minimus muscles on the right side, but rather weakness occurring for these muscles on the left side. And that's why I got that diagram a little bit incorrect. Essentially, the muscles on the left side are associated with ensuring that the pelvis on the right side does not droop when we lift the leg, because essentially these muscles are providing a counter directional force such that pulling down this side will cause for this side to go up, and that makes sense. So if we have weakness in the muscles on this side, then that will cause this side of the pelvis to not rise properly, and that will cause for it to droop. So whenever we assess for a Trendelenburg gait, we always say that the sound side sags. So the side of the pelvis that has sound muscles, so muscles that are working properly, that side always droops. So if we have, for example, weakness in the left gluteus medius and minimus muscles, we will cause for a drooping of the pelvis on the right side. And if we have weakness in the gluteus medius and minimus muscles on the right side, then we will cause drooping of the pelvis on the left side. So wherever weakness in muscles is present, the drooping of the pelvis always occurs on the opposite side. Now, something that I want to clarify in reference to the previous slide is that I incorrectly stated that the biceps femoris semitendinosus and semimembranosus is associated with hip flexion. Sorry, that was meant to be the gluteus medius, minimus, and maximus. So if there's weakness in that or pain in those muscles, that will cause an antalgic gait, but that was in reference with the previous slide. Now let's move on. Now, the next type of gait that I want to talk about is called a circumduction gait. And that's seen in this GIF here. And the reason why this gait is called a circumduction gait is that essentially there is a circular movement of one of the legs of the person that's been affected. So if you can see in this following GIF here, the man is unable to walk properly with his right leg, and he's sort of moving that right leg in a semicircular manner, if you can think about it. So as you can see, he's lifting his leg and it's moving sort of, if we draw his steps here, so his left leg is moving normally like that, but his right leg is sort of trying to compensate and moving like that. So this is the circumduction part of the gait cycle. So what actually causes a circumduction gait? Well, essentially, if we have a look at this gait, we can see, or that this GIF, we can see that there is very minimal flexion of the knee occurring compared to the left leg, because if you think about it, when you normally walk, your leg goes from that to that when you try to lift your leg upwards, but in this case, the person's leg is actually undergoing very little knee flexion. So obviously there's something wrong with the knee flexors in this case. So there is a pathology associated with these knee flexors, and in order to compensate for this weakness of these knee flexors, the person is lifting their leg to a greater extent to counteract that. And this lifting has been done by the knee flexors. Knee flexors as well as some back muscles. Sorry, what am I saying? Hip flexors as well as some back muscles. So there is weakness in the knee flexors, and compensation is occurring due to the hip flexors and back muscles. So a person presenting with a circumduction gait may complain of back pain and hip pain because they've been using these muscles excessively and over a long period of time. So another key thing to remember with this type of gait is that this person may present with a lack of ability of proper dorsiflexion of their foot. And by looking at this GIF once again here, we can see that instead of a proper heel strike phase, the person sort of lands with their feet flat on the ground. So a flat foot deformity is somewhat occurring here. So in addition to weakness in the knee flexors, we may also see weakness in the dorsiflexors of the foot. And the dorsiflexors of the foot include muscles such as the tibialis anterior, various other muscles that are associated also with eversion and inversion, which can also include the fibularis longus and tertius, as well as other anterior compartment muscles such as the extensor hallucis longus, extensor digitorum longus, and muscles such as that. So as you can see, a circumduction gait can be due to pathologies or weaknesses in various different types of muscles. And this can cause for an over flexion or over essentially contraction of the hip muscles, causing for an extensive clearance of the foot off the ground, a lack of knee flexion, and a lack of dorsiflexion, which causes for the leg to be pushed out to the side and move in a sort of hemicircular or semicircular manner. So the knee moves or the leg moves like that. Alright, the next gait that I'm going to talk about is the gait that I was talking about at the start of the video, which is not caused by any, or is very rarely caused by a pathology of the foot or the muscles of the leg or muscles of the back, but is rather caused by a pathology at the very source of where all motor innervation and balance and coordination comes from, and that is the brain. In this case, this type of gait is called an ataxic gait. And ataxic gaits are a type of walking that can be due to a cerebellar lesion. Now, if you know anything about brain anatomy, you'll know that the cerebellum is the part of the brain that is associated with coordination and balance. So if you suffer a lesion to the cerebellum, then your balance and coordination is going to be out of whack. So as you can see in this GIF here, this person is having a lot of difficulty walking properly because they are unable to balance themselves. So this cerebellar lesion can result from a head injury, a stroke, and it results in a gait pattern which there is really no pattern as such, and there is a wide range of a lack of coordination. So some key features of an ataxic gait include a lack of proper step length. Now, step length is defined as the length between the heel of the left leg and heel of the right leg whenever taking a step. So there is firstly an unpredictable step length. The person can also present, as seen in this GIF, with jerky and sort of hesitant movements. And in addition to this, as you can see with the looking at the person's feet, they're not very regular in their placement of the feet on the ground. So unlike the two types of gait or the three types of gait that we've looked in for the previous images, they had a constant pattern of either having heel strike or not, but in this case, this person is really only stepping on the ground with pretty much any part of their foot. So there is no regular foot movement, so irregular foot movement and placement is present. Now, another aspect to consider with the ataxic gait is that in addition to all of these pathologies or effects on the legs and feet, there are also effects on the trunk as well, because if you think about it, this is a condition that affects the brain. So all parts of the body are going to be affected. In addition to all of these leg effects, we also see a lack of deceleration. So the person is unable to decelerate themselves. If they pick up speed, it's unlikely that this person is able to slow down. And there's a lack of trunk control, because if you aren't able to allow for a proper control of your balance, then it's likely that you're unable to provide a proper ability to control your trunk muscles, which means that the trunk is affected as well. Now, this leads to people with ataxic gaits usually using support. So this may be in the form of a walker, a cane, or simply using their surroundings around them as a method of control, or properly allowing for them to walk. So having this condition is quite difficult. The next type of gait that I want to talk about is called colloquially a Parkinsonian gait, but usually medically is called a festinating gait. And a festinating gait, as you can see in this GIF here, is when it usually results from a person who has Parkinson's disease, and it's when this person is unable to walk properly, usually because of their tremors. So as you can see in this GIF here, this person, I'll change colors, this person has a very shaky hand movement, and these are the tremors that I was talking about. But in addition to the hands shaking, their feet are not walking in a very normal manner, and that is a result of the inability of them to control their muscles properly of their legs. And what that manifests as clinically or physically is that they have a very low clearance of the ground. As you can see, their feet are essentially shuffling across the floor, and their step length itself is very short. So in summary, a festinating gait is when a person shuffles, and another word for shuffling is festinating. And as I mentioned before, there is very little ground clearance. Another thing to keep into consideration is that a key part of the gait cycle for many people is the ability to swing a person's arms. And if you run or something like that, your arms usually swing by your sides in a flexed position. But as you can see here, this person has little to no arm swimming, so there is going to be a lack of balance as well. So little arm swinging, sorry, I can't talk today for some reason. Little arm swinging causes a lack of balance. And the key thing to also remember about this type of gait is that since this person is unable to clear the ground effectively, even small objects such as maybe sticks on the ground are able to allow for people to feel unsteady and possibly fall. And this is a very dangerous aspect of this type of gait, because usually we see Parkinson's disease manifest in older people. So if these people have a larger risk of falling in the first place and they're older, then that means that they have a greater risk of developing hip fractures as well. And I don't need to tell you the risk of hip fractures, because these particular fractures usually result in the death of that elderly patient within 1 year. So as you can see, the Parkinson's gait and the complications that result from a Parkinson's gait can be very, very dangerous. Alright, to finish off this video, I'm going to be talking about our last type of gait, and that is called a high steppage gait, or high step gait, and its name pretty much explains what it is. This patient, and its diagnosis is actually quite easy to do as well. As you can see in this GIF, if you look at the patient's left leg, which is this leg there, I'm trying to circle it, but it's the leg on this side of the video. They are landing their left leg, their right leg, I should say, with their toes first. Can you see that? And you can also see that they are lifting their right leg to a much greater extent off the ground compared to their left leg. So let's explore what is causing this in the first place. So a high steppage gait is characterized by clearing the ground to an excessive extent. That's what it gives its name, a high step gait. And in addition to this excessive lifting of the leg off the ground, there is a toe strike occurring as opposed to a heel strike. So in summary, this is a gait that lacks a heel strike. And obviously, as I mentioned before, landing involves the toes first. And there are a few key processes occurring that allow for the manifestation of this gait. Firstly, the mechanisms that allow for both of these pathological processes to occur include excessive flexion of the knees. So in order to compensate for the foot being unable to dorsiflex and allow for a heel strike, the knee flexes excessively. In addition to that, we have possibly the damage of some muscles in the leg which are causing this, but another compensatory measure is excessive flexion of the hip as well to allow for a greater clearance of the ground. And this is what manifests as that high step gait, because the patient is attempting to lift their leg to a greater extent off the ground. So the causes of a high step gait is that if we go back to the very crux of what causes this gait, it is an inability to clear the foot off the ground properly. And what that means is that we are unable to dorsiflex our foot and allow for a heel strike, which is instead why we cause a toe strike to occur. So if you think about the muscles that allow for dorsiflexion to occur, these are all the muscles that are present within the anterior compartment of the leg. So if we have injury of the anterior compartment of the leg, then we're going to have pathologies or weaknesses associated with the tibialis anterior, flexor digitorum longus, extensor digitorum longus, extensor hallucis longus, extensor hallucis, as well as other muscles present within this area as well. So this can be due to an L4 spinal lesion, or it could be due to a sciatic nerve lesion or damage, or even locally it can be due to damage to the deep peroneal nerve, which is the nerve that supplies the anterior compartment of the leg. And this is what eventually all of these injuries can cause for weakness of the dorsiflexor muscles. Alright, so in this video we've gone through a series of gait abnormalities. Firstly, we started off with the Ataxic Gate, which is when a person experiences excessive strain and an inability to walk properly due to a pain in their leg. We secondly looked at the Circumduction Gate, which is when the person swings out their leg in a circular manner excessively, which is due to pain in their legs as well as weakness. We then looked at the festinating Parkinsonian gait, which is a very low ground clearance, as well as a pill rolling or tremor-like movement in the person's hands. We also looked at an ataxic gait, which is when a cerebellar lesion causes for a lack of balance and lack of coordination. And we also looked at a high step gait, which is when, as you can see in this GIF here, the person is unable to walk properly, and that causes for a toe strike, which is due to a weakness of the dorsiflexor muscles. We also, looked at the Trendelenburg Gate, which is when there is an inability of the gluteus medius and minimus muscles to contract properly on the contralateral side, of which we're allowing for lifting of the leg to occur, and that causes for drooping of the pelvis on that side. So I hope you've enjoyed this video. This is a little bit of a different video. I've never really used GIFs in this video, in my video, so I hope they work properly. And I hope you enjoyed it. Thank you very much for watching, and I'll see you in the next video.